Welcome to Cardiology section number 10. Follow with us as we review venous disorders.
So phlebitis and superficial thrombophlebitis, it's inflammation of the wall of the vein. It can lead to clot formation. Typically when we're talking about somebody who has a superficial phlebitis, the thrombophlebitis means they have the small clot in the superficial vein. They'll have this palpable cord, they'll have this erythema, tenderness, and induration. So if it's just a phlebitis, the recent local trauma due to an IV catheter, or they're doing IV drug use, you just make sure there's no thrombus. And if it's just the phlebitis, it's just elevation, warm compresses, and non-steroidal anti-inflammatories. They may or may not get superficial thrombophlebitis, then you can treat them with an anticoagulation for a short period. But risk factors for phlebitis and superficial thrombophlebitis are recent IV that we put in the hospital, drug use, and then any of these hypercoagulable states can lead to this superficial thrombophlebitis. Varicose veins, it's because they lose their venous tension and the actual valves stop functioning properly, so the vessels kind of plump up. Typically they're asymptomatic. Some people will get this aching pain, focal edema, and they can get ulcers. Mild cases are treated with compression, stockings, and keeping the legs elevated, recommending exercise to build collateral circulation. But primarily varicose veins are treated conservatively. It's primarily you do surgery for those with significant pain or for cosmetic reasons. Venous insufficiency. This is diffuse loss of the venous tension creating stasis of the flow. These are the patients where the fluid actually escapes out of the vessel and into the leg. This leaves hemosiderin deposits there, and that's what causes the brownish discoloration. It also leads to stasis dermatitis. So stasis dermatitis and venous insufficiency, these two kind of go hand in hand. These patients often get these severe non-healing ulcers, and it's the medial malleoli that's the primary site of where you're going to see the venous ulcers. These are patients who people will say they're in congestive heart failure, but you'll listen to their lungs, they're completely clear, and they have this chronic leg edema. So that's how you're going to look at it. The risk factors are usually a DVT, usually obesity, or some sort of leg injury. And we already talked about the stasis dermatitis, and I talk more about this in the derm section. And now DVT. DVT and pulmonary embolus, they're one and the same. It's just where they're at. The DVT is in the leg or the source of the clot that goes to the lungs. So remember Virchow's triad, stasis, hypercoagulable state, and trauma. When we're talking about that stasis, anybody that's surgical or prolonged immobility, hypercoagulable, remember factor V and Leiden is the most common hypercoagulable state. They love to ask that question. Oral contraceptives plus smoking are common, and pregnancy is a big hypercoagulable state. And often it'll be a patient who's postpartum, has a syncopal event, what do you suspect, and it's a pulmonary embolus. And then any kind of trauma or any damage to the vessel itself. So somebody with a DVT, they can be either asymptomatic or they're going to have edema in just one leg, not both. So somebody who has venous stasis will be both legs swollen. A DVT will be just one of the legs bigger than the other one. You're looking for some sort of hypercoagulable state. Ultrasound is for diagnosis of the DVT, and your physical exam finding test that you do is called Hohmann sign. So Hohmann sign is basically you take the leg, you have it extended out, a little bit of bend in the knee, and then you just take the foot and you push it towards their head, and it'll cause pain in the calf, and that's considered a positive Hohmann sign. It's only positive in about half the patients who have a DVT, but it's still the test that they're going to talk about is a positive Hohmann sign is suggestive of a DVT. So the initial treatment for anybody with a DVT is IV heparin, and then you're going to switch them to warfarin. If they can't have anticoagulation, then you're going to put an IVC filter in. We rarely do thrombolytics for a DVT. It'd have to be massive, bilateral, and really occluding the blood flow. Otherwise, we just let them heal on their own.